Across the globe, an estimated 5 billion people lack access to safe, affordable surgical care. Within that deficit, neurosurgery represents a massive unmet clinical demand. Epidemiological models show that every year, 22.6 million patients suffer from neurological disorders or injuries that require specialized neurosurgical expertise, and at least 13.8 million of those patients require an operation. In many developing regions, health systems are currently navigating what is known as the neurosurgical transition. This transition forces hospitals to manage a compounding double burden. Historical baselines of infectious diseases and congenital anomalies remain highly prevalent, but they are now colliding head-on with a rapid surge in road traffic injuries and non-communicable degenerative diseases. To understand exactly how a health system absorbs this dual impact, we can examine a retrospective observational study tracking neurosurgical admissions at a single tertiary care referral center. The study was conducted at the National Institute of Medical Sciences University Hospital in Jaipur, India, capturing all neurosurgical admissions across a 24-month period from April 2022 to April 2024. The researchers compiled a dataset of 279 consecutive patient admissions. By deconstructing this dataset, we can identify specific patterns in patient demographics, analyze physician triage of treatment modalities, and evaluate final clinical outcomes. Analyzing how a specific, resource-constrained hospital manages this workload provides a direct blueprint for understanding the reality of global neurosurgical triage today. This chart shows admissions divided into diagnostic categories. Traumatic brain injury heavily dominates, consuming 56.6% of the total workload. The secondary burden falls into elective structural care, with degenerative spine diseases making up 16.8%. Finally, neuro-oncology represents the tertiary burden at 9%. The remaining dataset fractions are divided among low-volume but clinically vital categories, such as vascular disorders, infectious and inflammatory conditions, isolated traumatic spine injuries, congenital anomalies, and peripheral nerve disorders. When we align these pathologies with the demographics of the patients, clear risk profiles emerge. Neurotrauma operates as a silent epidemic, targeting a highly specific segment of the population. This demographic chart reveals distinct risk profiles. TBI patients average 34 years old, with a staggering 77.2% male distribution. Conversely, degenerative spine patients present later, averaging 49 years old with a balanced gender ratio. Predictably, congenital anomalies skew entirely pediatric, averaging 4 years old. The demographic skew in the neurotrauma cohort is an environmental byproduct. Rapid motorization creates highly dangerous road traffic conditions, and industrial development increases exposure to occupational hazards. Both of these forces disproportionately affect young males. Because TBI hyper-targets young, working-age men, the injury frequently removes an active breadwinner from the household. In low-resource settings, this loss of productivity rapidly forces families into catastrophic health expenditures. Of the 279 patients admitted, 54.5% received operative surgical intervention. The remaining 45.5% were managed conservatively, with pharmacotherapy, observation, or physiotherapy. That aggregate split obscures how treatment decisions are actually made. When separated by diagnostic category, the choice between conservative and surgical care becomes highly polarized. This chart breaks down the treatment modality distribution. Pathologies defined by structural lesions mandate operative intervention. Congenital anomalies show a 100% surgical rate, and tumors follow closely at 84%. These conditions require physical remediation, such as craniotomies to excise tumor tissue, or endoscopic third ventriculostomies and shunts to divert fluid in congenital hydrocephalus. Degenerative spine disease also heavily favors the operating room, resulting in a 72.3% surgical rate. Here, surgeons perform microdiscectomies, decompressions, and lumbar interbody fusions to resolve severe refractory nerve compression. In direct contrast, vascular disorders and traumatic brain injuries display large conservative components. Vascular cases were managed conservatively 64.3% of the time, and TBI cases 55.7%. For spontaneous intracerebral hemorrhage, global trials like STITCH 2 and current guidelines dictate that strict blood pressure control and intensive care observation are often the most effective baseline protocols. Similarly, conservative TBI management relies on close observation, anti-epileptic medication, and hyperosmolar therapy like mannitol to manage swelling. Patients in these categories are only pushed into the surgical pathway when extreme criteria are met, such as large hematomas causing mass effect or intracranial hypertension that refuses to respond to medical management. Furthermore, based on established data from the MRC crash trial, physicians explicitly avoid administering routine corticosteroids in these trauma protocols. The allocation of operating room resources is completely dictated by clinical urgency and strict adherence to evolving, evidence-based global guidelines. To measure success, the study evaluated clinical status at discharge, sorting patients into 3 categories. Green denotes full recovery. Orange denotes partial recovery, indicating a need for ongoing rehabilitation. Finally, red denotes a severe outcome, defined as severe disability or a vegetative state. Overall, 47.7% achieved full recovery, 31.9% had partial recovery, and 20.4% experienced severe outcomes. Elective structural interventions produced favorable results. Degenerative spine and congenital cases carry heavy green majorities, proving surgical correction effectively restores baseline function. Emergency conditions show a starkly different reality. The trauma and vascular categories carry a heavy red footprint, holding the highest severe outcome burdens in the cohort. When we isolate the TBI subgroup and compare its 2 treatment pathways, a seeming paradox emerges in the data. Looking at Figure 3b, TBI patients managed conservatively achieved full recovery 63.6% of the time. Conversely, TBI patients treated with surgery faced severe outcomes 40% of the time and achieved full recovery only 21.4% of the time. This data does not indicate that surgical intervention is a failure. It reflects the strict triage criteria applied upon admission. Patients selected for decompressive craniotomies possess significantly greater baseline injury severity. The surgery effectively achieves its primary goal of reducing mortality, but because the brain was already extensively damaged, the survivors are left with profound disability. Emergency neurotrauma surgery saves lives, but that survival frequently comes at the direct cost of severe long-term morbidity. This dataset maps the operational reality of the neurosurgical transition underway in low- and middle-income countries. Hospitals are forced to execute a complex balancing act, actively managing a high-volume acute trauma epidemic while simultaneously preserving the capacity to resolve chronic degenerative conditions. The authors note specific methodological limits to this study. First, as a retrospective review of a single tertiary referral center, the exact admission ratios may not perfectly scale to all developing environments. Second, because clinical outcomes were recorded strictly at discharge, long-term functional recovery, delayed mortality, and overall quality of life remain unknown. Finally, the statistical analysis is entirely descriptive. It maps the current burden but cannot offer causal inferences comparing the efficacy of surgery against conservative care. The research was conducted with institutional ethics approval, required no informed consent due to de-identified records, received 0 specific funding, and the authors declare no conflicts of interest. Generative AI tools were utilized strictly for manuscript language formatting. Because neurotrauma aggressively targets young, economically active populations, and because surgical intervention in severe cases yields high rates of disability, building more operating rooms is an incomplete solution. Increasing surgical capacity addresses the end of the crisis, not the root. To improve overall outcomes, health systems must integrate targeted road safety enforcement, robust critical care triage, and extensive long-term rehabilitation pathways, all operating in tandem with preserved elective surgical capacity.